for physicians, for interventional cardiologists, for those who do heart and vascular procedures. This is a peek into the future. It's an amazing that we now have or are developing a tool that gives us an AI generated guidance for treating blocked coronary arteries. And that guidance we receive before we ever start the procedure to open a blocked artery. So it's a comprehensive AI tool that, in my mind, guides our therapy, giving us two very important pieces of information: anatomical and physiologic assessment of the blood vessel. In other words, what does the artery look like and what challenges that look presents for us in the cath lab when we're trying to open that artery, but also how the artery functions, because not every blocked artery needs to be stented, bypassed, whatever. So we get both anatomy and physiology of the blood vessel. And I think we're looking really at what is the future of cardiovascular therapies. Now, with that, you know, helicopter view, Mike can give you the scientist view of the what and how.
Yeah, thanks for that. Dr. Rizik, as always, has done a beautiful job of setting the table and really providing nice perspective on where we are and where we're going. And I think what this really represents is a natural evolution of a journey that we really embarked on, almost a decade ago, if not more. Whereby we're taking um, anatomic information that we've had for many years available to us in the coronary CTA. But now, through increasing levels of sophistication, deriving first functional information, the physiology that Dr. Rizik so nicely mentioned, and now even a step further with the addition of further AI refined analysis, enabling us to quantify the type and extent of atherosclerosis present in the coronary arteries, and then finally now integrating all this information together in a single UI platform, which then really enables the interventionalist now to use this information to enhance their delivery of care for the patient. So these are tools like on a, basically like a menu analogy. We've had these different options available on the menu, but really in a more piecemeal meal way. And really the challenge has been to integrate these in a way that is usable and easily accessible for our interventional colleagues so that they can translate it into care delivery. And now, for the first time, we really have that available. We have these sophisticated tools that have been available to us, but not really available in one package. That now they can easily take these different aspects of information, the patient specific anatomy, the physiology, the plaque composition, and integrate those things together for really optimizing care delivery.
My first coronary intervention in the 1980s. It was primitive, unsophisticated, and about as much sophistication as we had back then. We saw a 50% blockage. And back then we said, oh, anything more than 50% needs to be, angioplastied or bypassed or whatever. And that was um, so unscientific. There was no scientific merit to that, to proceeding along those lines. And we tried to say, well, okay, what 50% blockage needs to be treated, whether it's bypass or stenting, and what 50% blockage does not need to be treated. And what you just described is this very comprehensive tool, this methodology. you know, I always say, Ryan, if the artery, if it's an important artery and it's 10% blocked, you don't have to do anything about that. That does not need to be treated. Again, whether by bypass or stents. If it's 95%, well, then it's always going to need to be treated, or most likely. Well, we're between 10 and 95. do we draw our line? Is it 40, 50, 60, 70, 80? We really didn't have an integrated scientific tool to give the the surgeon or the doctor this information until now. And the beauty is we have the information before we ever start the case.
Yeah, I think that's a great point. And really, if I maybe I can amend my previous statement by saying, when I talk about this journey beginning 10 years ago, it actually begins even further than that. Like Dr. Rizik said, this principle of moving from anatomy to physiology with the FAME trials more than 20 years ago now really demonstrating that very important principle. And what we're seeing now is the evolution from where we would have to initially gather that information on an invasive basis, where now we can increasingly get this information non invasively, which not only allows us to better triage patients in terms of who needs to potentially go for interventional or invasive therapy, but now even taking a step beyond and allow us to potentially, in a more refined way, understand from a treatment planning perspective which particular patient is going to benefit from more intensive interventions, for example, versus other forms of therapy.
Well, I think we're still in the embryonic stages of that, but we're just using CT, um, just using the CT or the FFR technologies that we currently have? The answer is, of course. I it has having this information has done several things. Number one, if it is going to be a stent procedure, it guides my the technologies I'm going to use, whether we use a rotoblader or like a drill to drill through the calcium, whether we use lithotripsy to treat certain types of calcium, whether or not we're going to use a, a synergy of devices, how long the stentage segment should be. If we're going to put a stent in, it tells us the length of the blockage or what we call the lesion. So how long the stent should be. Um, it gives us a lot of information of those anatomic obstacles that we need to overcome to get a very satisfactory result. But it also gives that's once I've decided I need to treat this vessel, that's what it provides me. But prior to that, it answers the question, do I even need to and I'm gonna use the word fix, and fix loosely means bypass or stent. Do I even need to address this vessel? Do I even need to fix this vessel? Does this vessel need a therapy based on the FFR, the functional assessment? So it totally changes that. But I'm gonna take it one step further. It also helps me to have a discussion with Dr. Morris, with my interventional colleagues, but also with the surgeons as to, well, maybe this is the type of blockage that should not be stented, but rather bypassed. And conversely, this is straightforward or simple enough or appropriate enough of a vessel to treat with catheter-based technique stents rather than bypass. This patient really doesn't need a bypass. So it answers for me in the cath lab as the doctor who does the angiogram and then has to decide, does it need to be fixed? If it does need to be fixed, which modality, stents or bypass? And if it is stents, um, uh, what are the obstacles to that I need to overcome for success? And then even when I'm having a talk with my surgical colleagues, let's say there's 3 or 4 arteries which have disease, I can say to them, you know, artery 1 and 2 definitely need to be fixed based on the functional assessment, the FFR. But artery 3, even though it's 50 or 60% blocked, the functional assessment is negative. You really don't need to fix that. You don't need to bypass that. So it just answers so many questions that previously we haven't had the answers to.
Yeah, and I think I'd like to follow up by saying, there was such an eloquent way of framing the response in terms of how we think about it from a paradigm perspective. And broadly speaking, I think the technology has really two potentials. And as Dr. Rizik mentioned, we're really just at the early stages in understanding how best it can be utilized. But I think conceptually thinking about it in two ways. Number one is really the goal is to, with tools like this, make decision making as objective as possible. Removing areas of subjectivity to enhance predictability of outcomes and treatment response. And in one sense, what this technology, the promise of this technology, is that really democratizes access to expertise. So if you're fortunate enough to be in a location where you have someone like Dr. Rizik, who's really at the pinnacle of expertise and understanding, uh, versus other areas where there may not have access to that same level of expertise. A tool like this potentially can elevate all users to operate at a very high level, giving them access to the same sort of thought process and experience that someone like an expert user like Dr. Rizik has. So, really elevating access to expertise for all patients. But then number two is now for all users is accessing um, the technology in terms of the physiology, the patient-specific anatomy, and the plaque composition now to enhance decision making of all users to further refine the care delivery pathway. And we have some early data now, for example, that demonstrates that at TCT, as Dr. Reisig knows, there was a case presentation on using the plaque quantification, for example, to refine interventional decision making, showing that in about 50% of patients, it actually impacts how you're going to be thinking about doing calcium modification on certain subsets of patients with that type of atherosclerosis. So we're really now trying to translate the potential of this software into really understanding how we can inform care delivery and improve decision making and interventional therapy.
I want to say it's a great equalizer.
Mhm.
We said when stents first came out, in everything, whether you're talking about baseball players or interventional cardiologists, there's a spectrum of talent and experience. And I'll never forget someone saying at the beginning of the stent era that stents were so easy to use and made results so reproducibly satisfactory across the spectrum of experience and talent that the word they used was stents were the great equalizer. It sounds like in some ways you're saying this is another one of those equalizers in the spectrum of talent and experience in the cath lab.
Yeah, I think that's really the paradigm in which we're operating under. We don't yet have the data, of course, to validate that because it's so early on. But many people feel, as do I, that that's really where it's going to go for exactly the reasons that you've articulated.